Good afternoon, everyone. John Snyder here for Thursday's Newton-Wellesley Medical Group Lunch and Learn. We are happy to be back from our summer recess in August, and we're really happy to kick off our series in September with Dr. Jeff Phillips, who's going to talk to us about virtual care, where we are and where we are going. Next slide, Jeff, if you can. So we want to tease the upcoming Lunch and Learns, which are in your box right now. Next week, we have Avoiding Pitfalls in ENT Diagnosis with Sam Bott. Following, we have a nice dermatology talk with Dr. Beda and Dr. Doe. And then at the end of the month, we have another dermatology talk about rashes. Can't get enough dermatology, especially in September. We also want to make sure folks know on Wednesday mornings at 8:30, Dr. Larry Friedman puts on a great series on Grand Rounds, and next week is M&M Grand Rounds. So we want you to encourage you to join that. CME is available for there. Our talks are all posted up on our website, on our intranet, Newton, as well as on YouTube. You can easily find them by searching Newton-Wellesley or hitting on Newton-Wellesley Medical Group Lunch and Learn or hitting on the link here. Next slide, Jeff. Two programs we want to make sure folks know about as a practicing clinician in the area. One is our Newton-Wellesley Orthopedic Walk-In. You all know about our emergency department and the volume level at the emergency department and as well at in our hospital. And this program at this office is open 7 days a week, Monday to Friday, 8 a.m. to 8 p.m. And on Saturday and Sunday, 8 to 1. It is fully staffed with x-ray, casting capabilities and orthopedic specialists, orthopedic surgeons, and orthopedic physician assistants. So we want to make sure that is available. You guys know you can send your patient there as a walk-in, or you can call ahead and make an appointment. Next slide. And we did announce this last week, and we ran our first Newton-Wellesley Hospital thyroid biopsy clinic. It is a new weekly multidisciplinary thyroid biopsy clinic. We have an endocrinologist, thyroid surgeons, a cytologist, and the radiologist all in one location. It's intended to provide up-to-date, streamlined care to your patients with thyroid nodules. Patients may be referred if they have the categories here: a nodule greater than 1 centimeter, suspicious, if it's an FDG avid lesion, or if it's palpable or symptomatic. You can always call. There's an email address listed here, as well as you can use our Epic referral looking for thyroid biopsy clinic. We're really excited about this program, bringing all our specialists and expertise around your patient who has a thyroid nodule. So please take advantage of this program. You will not be disappointed. And I believe I'll turn it over to Jeff. Thanks, Jeff. Next slide. Yeah.
All right. Yeah. Thanks, John. Thanks for having me, and everyone, thanks for giving me a half hour during lunch. No gross photos today, so feel free to eat your lunch. I think there's one oropharynx you may see, but that's about as graphic as we're going to get. So enjoy. I think I know most of you, but I'm a primary care at Wellesley Family Care. I also work at the Virtual First primary care practice and the virtual care site lead. We're going to talk today about virtual care, sort of a state of the state, where we are and where we think we're going in this sort of rapidly evolving field. I want to talk about our inpatient programs briefly. Those sort of fly under the radar, but there's some really cool stuff going on in the hospital around virtual care. We'll talk about virtual visits. We'll talk a little bit about the Virtual First primary care model, and then we'll prognosticate a bit on the future. We should have some time at the end for questions, so feel free to throw them in the chat as they come to mind, and we'll get to them at the end. So I want to talk a little bit first about inpatient virtual care. Through the course of the pandemic, we actually stood up, MGB as a system, stood up two really cool platforms. One is called CareTeam Connect, and the other one is called Patient Connect. And these are, two tools that initially were very rudimentary, but have sort of continued to evolve to the point where, now I think they, they're actually quite useful even in sort of non-COVID situations. So CareTeam Connect, this is the way to think about this: is a patient who is admitted into the hospital. They have an iPad at the bedside that's either sort of trained on them on an IV pole or a stand, or they're sort of grabbing it the way that this patient is, and the care team can sort of pop on anyone on the care team. So the nursing staff, the physicians, anyone with basically MGB credentials can pop onto this iPad and chat with the patient while they're admitted. Talk a little bit more about that in a minute. And then we also have Patient Connect. So this is a way to connect inpatients with family and friends while they're admitted. And you can think of this one as basically a way to set up a FaceTime call. Essentially, I mean, we use Zoom, but these are for patients who maybe don't have their own phone, don't know how to use video. They're admitted, they want to speak with their cousin in Newton or their cousin in California, we can set that up for them. So a little bit about CareTeam Connect first. So again, this is an iPad in the room. It's often set up facing the patient. Any remote clinician with MGB credentials can sort of pop onto that device. A lot of ways you can get on there. So you can use the Volt phone. And I know the nursing staff really enjoys this because they're carrying them anyway. You can use your personal phone. It supports Android or Apple, an iPad, a laptop. It's really omni-channel. You just need a video and a speaker. The patient doesn't need to do anything. Obviously, they need to give consent to have this iPad at the bedside. But then, once that is done, basically anyone can sort of pop on. So this is actually really great for intubated patients. This is great for patients who, have decreased mobility, for patients who need to be closely monitored. And again, Zoom is now the underlying technology. So, there are a lot of current uses at Newton-Wellesley. We sort of have a number of like little pilots out there. We have some of these available in the ICU. We just set up a few devices in the special care nursery so that, basically new parents or grandparents or whoever can pop on and see, the new baby when the baby is in the nursery. That's actually part of the Patient Connect platform, but it's essentially the same idea in terms of having it set up and trained on the patient. We have a couple in the ER, on the psych floor, and then we started a really cool program that Dr. Parpos leads, cardiology consults being done by cardiologists at the Brigham. So these are patients who are admitted to Newton-Wellesley. They need a cardiology consult with someone at the academic medical center. And so our cardiologists sort of arrange this, and they have sort of a triad with the patient and our cardiologist and their cardiologist to do these consultations. There's a nice quote here. I'm not going to read it. This is a quote from a nurse who's used these and says, basically these are great for COVID, but these are going to be great for post-COVID as well. And I think we're certainly thinking about that as we're designing these tools. This is just a screenshot to show how one might connect. This is a just a link actually from my iPhone from a few months ago. There's a CareTeam Connect app there. You click on that, it brings you to a web app, and then you can choose which room you want to pop in on. And again, this is a similar interface if you're going to go on through the web or through an iPad or a Volt phone. So just switching gears, this is Patient Connect. So again, this is more of sort of the visit from a friend or family member, a virtual visit from a friend or family member when someone's admitted. And this is often for patients who don't have their own phone or are sort of unable to do so. I think the most important slide is this one, which is if you are interested in doing something like this, we are not asking the nurses to take this on. We're not asking the providers to take this on. We have a resource for this that's been supported by MGB. So we have a virtual care coordinator. His name is Rahat. He's fantastic. He's in the hospital from 11 to 7 during the week. This is how you can get in touch with him. Really sort of omni-channel, page, email. He's on the Volt system as well. And his job is to coordinate all of this for you. So, if someone says, oh, I have a patient in room 603 who wants to talk to their nephew, he takes it from there. He'll schedule the call, he'll send the invitations to the participants, he'll deliver the iPad if there's not one in the room, and he'll collect it as well. So please, please, please use this resource. If we don't use it, I'm sure we're going to lose funding for it. So yeah, again, we're not asking people to set this up on their own. And just thinking about the future a little bit for inpatient virtual care, we're still sort of early stage, but the vision here is an iPad in every room. And you can sort of think of this as when the room gets turned over, the iPad gets turned over, meaning it gets cleaned and it gets digitally cleansed. So all the patient sort of identifying information gets wiped. So the next patient shows up in the room and they can start fresh. And you can think of this as sort of a Swiss Army knife with a bunch of cool apps on there. So CareTeam Connect, Patient Connect. Many of you are familiar with MyChart Bedside, which is an Epic application that allows patients to be more engaged in their hospital stay. That is on the horizon. You could certainly imagine once we have one of these in every room, we can set up a system that PCPs could actually check in if they wanted to see their inpatients and just pop in for a quick 5-minute visit to say, hey, you're in good hands. I look forward to seeing you, on discharge. I think patients really would like that. That's something we could set up once we get broader adoption. And then interpreter services, I'll speak more to this when I talk about virtual visits, but this is coming real soon to virtual care, and I think will be a sort of quote unquote killer app for the inpatient side as well. All right, so let's talk about virtual visits. So we've done a lot of these. This is the trend at Newton-Wellesley over basically since the pandemic started back in April of 2020. It's not perfect data. We're actually up over 400,000 or so, but this is as good as we can get from the MGB dashboards. You can see, just really that blue line under appointment trend. Don't worry about the orange line below it. The blue line is basically showing the number of virtual visits that were done at Newton-Wellesley each month. And you can see it's sort of starting to stabilize somewhere between 13,000, 10,000. Last month, it actually bumped up a little bit again due to the Delta variant. And then the graph below, the bar graph there, shows the different types of virtual visits that are being done. So the dark gray is the Epic integrated through Zoom, which is really the majority. Then the orange are the Doximity type visits. And then the blue, the sort of mid-level blue, there's telephone only or audio only virtual visits. So I won't belabor this. You guys have heard me talk about this before. I just want to drive it home. Patients really like these visits and they really ask for these visits. The Net Promoter Score, which we collect through the NRC platform for virtual visits, are higher than our in-person visits. So patients are reporting that they would recommend these over in person. And we're finding out now a lot of really interesting work coming from the advisory board. The ability to offer virtual visits is now a deciding factor in how patients choose their provider. So patients are actually kind of starting to shop around for this. There's some really cool quotes here. I'm not going to read them. The top one, is from a 71-year-old who's just very happy to be able to do this virtually. We've got someone, 3/4 of the way down, a mom of 2 children. It's tough to get an appointment, tough to find the time. And then we've got a patient down below that with sort of limited mobility. So your patient who takes the whole day, to get a ride and come into the office. If you don't need to do a real in-depth physical exam in person, you could certainly think about doing these virtually or every other visit virtually. I just want to quickly mention audio only virtual visits. We've certainly been pushing video, and I think, video is generally preferred. However, it really is not for everybody. If you use especially app-driven video platforms that force a patient to download an app, there's actually some early data that shows this can worsen the digital divide, meaning the people who are sort of, very digitally literate and those who aren't. So, in this case, patients with great healthcare access already, white and wealthy, get even better healthcare access, while people, who do not fit that category are shut out from these new tools. So, particularly we worry about some of our older patients, lower socioeconomic status, health literacy, people of color, and the limited phone data plans is a huge thing. Most people in this country do not have unlimited data. They go month to month with their phone plan. So a virtual visit through Zoom could take, 25, 50% of their data bandwidth for the months they may not want to do that. So the point is, in some cases, phone is okay. You want to sort of choose your patients, carefully for people who really don't have another option and this is their best platform. There's a really nice article that a few people forwarded to me, New England Journal of Medicine, last month from a provider who was really excited to start sort of doing video visits with everyone, and they were in an underserved area and found out that they were just doing, essentially all phone visits. And really sort of what they learned by doing that, really liked doing that, got very good at listening. It's a really cool piece. So just something to keep in mind for these patients who can't get on video. So these are our options, right? We've got our Epic integrated Zoom, we've got Doximity, and then we've got the phone, which still works. I want to talk a little bit about risks for virtual visits. Everyone's always worried about not doing an in-person physical exam being the biggest risk. That it hasn't even scratched the surface of being one of the larger risks. The biggest risk, according to Crico and others, is distraction when you're doing virtual visits. So, we all do this, right? You're doing your virtual visit, you've got your email open, you might have a chat window open, you've got, whatever, Slack, Stocks, I don't know. That's actually considered to be the biggest risk. So really important, you want to shut off your notifications, you want to close every other window except for Epic and Zoom, unless you're kind of sharing something with a patient or using Doximity. It's just too much in our nature as human beings to get that little dopamine hit by, refreshing your email or, whatever it is. So really important. On the patient side, distraction is also seen as the biggest risk. They're not hearing you, they're not sort of listening to medical advice, they're missing instructions or follow-up. If your patient seems to be distracted, this certainly has happened to me. I see them kind of looking to the side, they've clearly got another window open and I don't know what they're doing. Feel free to remind them nicely, hey, this is like a medical visit, should we reschedule for another time? And then driving. So I don't know if this has happened to any of you, but I've had now 3 patients go onto Zoom and they are on the road. They've got their phone either like this woman or it's sort of, propped up. But either way, we do not want them doing medical visits by video while they're driving. So you ask them to pull over or you ask them to reschedule. A little awkward, but I think they get the message. So I also get this question a lot, what's sort of appropriate for a virtual visit? It's a big question. There's no easy answer. I can tell you MGB is currently drafting policy on this, but where they're going is that it's ultimately going to be left to the discretion of the provider. So MGB is not going to say you can't do a physical via virtual visit or you can't do a knee exam. They're going to say it's really up to you. So, essentially anything without the need for urgent in-person exam is appropriate as long as the provider is comfortable, and there's going to be varying degrees of comfort. Remote patient monitoring can help you be, I think, quite a bit more comfortable. If a patient has a blood pressure cuff at home, that gives you a lot of information in terms of their vital signs. Activity trackers, Apple Watches these days are quite accurate. Fitbits are quite accurate. And then if they have an O2 sat monitor, if that's appropriate, that all counts. So, feel free to utilize that, especially if a patient who's doing a lot of virtual visits. This is really just for reference. This is what our primary care team's front desk is using in terms of scheduling patients, whether they should be scheduled virtually or in person. Now, providers are certainly sometimes overriding this and saying, I don't want to see anything virtual. I want to see almost everything virtual. But this gives everyone sort of a template to look at if they're interested in sort of starting with some guardrails around this. All right, this is the grossest picture, I promise. So, so some physical exam pearls here for virtual care. So images are really important. So it's often helpful to have patients send images prior to the virtual visit if you can through Gateway, because the resolution on something like this is much higher than you're going to get by having them bring their mouth to the camera of their phone or their laptop or whatever. So prior to the visit, and if not prior, afterwards, say, hey, that's really interesting. I need you to send me a Gateway message with a photo attached so I can take a look. MAs and providers can be trained to do this. If they see the reason for the visit as a rash, they can reach out to the patient ahead of time and say, hey, can you send a photo? Our MAs are now, really well trained, I think, in helping patients check their own pulse, obviously their weight and their respiratory rate. So a patient MA, patient meaning they have a lot of patients, spending time with them, walking them through, counting to 60 while their fingers on the pulse can be really helpful. And then one tip that I think we often really forget to do or just underutilize is asking patients to flip the camera. I don't mean to flip the phone. I mean to click that button that flips the camera around so that you can see what they can see. This is great for looking in the oral pharynx. This is great for looking at rashes. It helps patients kind of coordinate themselves because otherwise they can't tell what you're seeing. So just a little tip. And since I've started doing this maybe 2 months ago, very helpful. So the other thing that's important for physical exams and virtual is getting the patient to help you. So, this is someone who's doing, teaching a patient to do a lymph node exam, kind of walking them through it. They're not clinicians, right? But they certainly can find a big lump in their neck. And for patients who, this is not something that, is sort of life or death in that moment, you can walk them through it pretty well. And same with abdominal palpation. The hardest part there is getting them to relax themselves by putting their legs up because they tend to guard. For people who want to learn more, Stanford actually put out a really great program. They walk you through the full training of a full physical exam virtually. So check it out. This is the link. Some great videos. It's actually very, very well done. So just real quick, privacy. Just remember when you're doing virtual visits, keep in mind who might not be on camera. A controlling partner, abusive partner off camera. Just, if someone's doing it in the workplace, just coworkers in the background. So, you want to ensure your participants have some privacy. You also want to be mindful that asking about privacy may be somewhat triggering for people. So, same as in the exam room, right? When they come in, they could bring a controlling partner in with them, and that's going to affect the visit significantly. So all of the sort of major telehealth companies will say, you are supposed to ask, are you in a safe, private place to talk? Our domestic violence folks have some concerns about that and thinking that could potentially be triggering. So, I sort of go in the middle and say, hey, is this an okay time and place to talk? Not really specifically calling out safety, but giving them the option to say, no, maybe we should reconnect later or something like that. Regulatory, we've like crushed this ad nauseum, but basically, excuse me, sorry. Essentially, if you are a provider and you're only licensed in Massachusetts, you should only be taking care of patients who are in Massachusetts at the time of the visit, unless you have a license in another state. As a provider, you can be in another state. You can be in New Hampshire taking care of patients who are in Massachusetts with your Massachusetts license, but you need to be in New England. I think we've killed this previously, but just a reminder, please feel free to reach out to me, any sort of specific questions around that. Documenting virtual visits. This has come up a lot lately since the state of emergency has ended. So, we have, and I still see these all the time in notes, is sort of long language about this visit was done virtually due to the COVID pandemic, the state of emergency, et cetera. You no longer need that at all. All you need to do in your note now, if you want to put it into a smart phrase into your note, is just use the VB attestation note smart phrase. This is updated by MGB, the central team. You don't need to remember anything. You don't need to change anything. You could put this in here. The other way to do it, you don't even need to have this actually in your notes separately. If you're closing out your Epic chart, you see the virtual visit attestation piece there in the wrap up. This is almost entirely auto-filled for you. The modality is based on the encounter type. The provider location is based on what you said on your COVID pass when you signed into Epic that day, whether you're remote or not. And the patient state is based on the decision tree that your staff had to fill out when they were scheduling the virtual visit. So this is really just to kind of see it and sign off on it, make sure that there's nothing incorrect there. But I think the central team did a nice job of trying to make this automatic, so we don't have to waste our time with clicks here. Reimbursement for virtual visits. So this is just, a hot potato right now. There's a couple things we know, and there's a few things we don't. So we know that behavioral health and psychiatry will continue to be paid the same rate that they're paid for in-person visits forever in Massachusetts. So that one is pretty straightforward. Primary care will continue to be paid on par with in-person visits through January 1st of 2023. And currently it's being debated what's going to happen after that. Chronic disease management is in the same bucket, January 1st, 2023. The big question there is, how do we define that? How do you define a chronic disease, and how are we going to document that? And that's being discussed right now, whether we're going to have to click a modifier when we bill, whether it's going to be based on the diagnosis, whether it's going to be based on the provider type. That is sort of very much up in the air. So much more to come. You guys will all be hearing from me in the coming month or two as decisions are made around this. So for now, keep doing what you're doing. I want to talk just a little bit about our virtual first primary care practice model. So I think, I've mentioned this before to everybody, but this is a practice, and our goal is to deliver as much care virtually as we can when it's safe and effective. Our rate of virtual visits is about 92% last I checked. So we're not seeing very many people at all in the office. We're open to MGB employees with always and their dependents. It's interesting, mostly who we're taking care of are residents and fellows at the academic medical centers who otherwise wouldn't get a PCP. And this has really been a great model for them. Outside of the actual sort of care model, we try to do a lot in terms of sort of office work and contact with the practice, try to make that digital first as well. We know that patients hate the phone. There's no greater dissatisfier than phone trees, especially if it dumps you into, one, if it hangs up on you, or two, if it dumps you into a voicemail. So, we try to use digital as much as we can. We use Patient Gateway a lot. We use e-check-in. We do direct scheduling, which is patients can directly schedule themselves right into our schedule, and open scheduling, which means brand new patients to MGB can do the same thing. And we do a lot of emailing with our patients, not about medical issues, but about sort of setting up appointments and sort of back office functions because they prefer it. So this is this is just our website for Virtual First, and you can see, the first thing that people kind of get hammered with is scheduling. So self-scheduling via Patient Gateway for existing patients, and new patients scheduling online. So we're really trying to make this as as digital as possible and keep people off the phones. So open scheduling, again, for people who aren't familiar, right now we're the only practice at MGB who's live on this. But this provides a path for patients who are brand new to MGB to self-schedule. They click in, they say they want an appointment, they pick a time, and then it asks them some information, not the full registration, but it schedules them. And then we have our front desk review and make sure it was sort of scheduled appropriately. And again, this is just a real patient satisfier because they do not like the phone. Just a couple examples of how we're really trying to maximize patient gateway. The patient gateway does a lot, and MGB really, I don't think leverages it quite as much as we should. This is real kudos to Scott Blatterman, who has developed all of these smart phrases. And these smart phrases actually include these little snippets of screenshots. So this is, a patient being reminded they have an upcoming appointment. This walks them through exactly how to do the e-check-in. It has really nice sort of patient-friendly language on here. It's not sort of the standard MGB boilerplate legal language. It's much more sort of warm and friendly. So if anyone is interested in, using any of these, please feel free to reach out to me and Scott Blatterman. We're happy to share these with folks. Scott does the same thing. He's got a great gateway message here that walks patients through how to get their medical records from outside of Epic and import them into Epic through Care Everywhere. Patients can do this on their own now, and very few do because it's sort of hidden somewhere in Gateway, but this walks them through that. And so, again, it's sort of like what's important to our patients. And this isn't just at the virtual first practice. This is, throughout our system, it's same next day access. That's the most important thing for folks. Then it's convenience in terms of location and having virtual visits. Then they care about the network. Then they care about having a great positive experience, and kindness here matters a lot. And then there's sort of the digital experience. So, gateway scheduling, all of the stuff that we've been talking about. So what does the future look like? Well, we're not sure. The short-term future, this is very exciting. So we're going to have video interpretation coming within 45 days. I'm going to be pessimistic and say 45 days. I think it's going to be sooner than this. But essentially, this is a video interpreter for your virtual visit through Zoom. And this is going to be 2 clicks. So you're in your visit, you click that button that says interpretation, and you choose the language. There's 40 languages that are supported by video and 200 that are supported by audio. And within 30 seconds, somebody will come on. It's a video, it's a person on their video, and they'll be an interpreter. So this is on demand. So we are really excited about this. So this will be at virtual visits for Zoom. And this will also be available in the CareTeam Connect app that I mentioned earlier on the inpatient side. So really exciting. And then I think, looking sort of further down the road, right, we want to make the funnel bigger so that patients can sort of access us how they want to access us. And even if we're kind of funneling them more towards a visit or a virtual visit, a lot of people, just specifically millennials and Gen Z, they just don't want to pick up the phone. So if you have a chat bot, if you have, you can text, right? You could text with a triage nurse who could sort of appropriately triage these folks. Patient gateway messages, e-visits are coming next month. So you'll be hearing more about that from, Rick and myself. And virtual visits and in-person visits. So we really need to be able to kind of meet the needs of our patients along this entire spectrum of care. So we're not just saying, just come into the office all the time. I think, the real future of virtual care is virtual care is just healthcare. Like, we won't have to have a talk specific to virtual care because it'll just be something that we all do. And, the virtual first practice is a way to sort of put our foot in the water with this, but ultimately we really want to kind of infuse all of our practices, with this mentality, going forward. So I will stop there. I'll stop sharing.
Thanks, Jeff. That was a great survey. If anyone has any questions you want to throw in the chat box. Jeff, you want to comment? We're getting some questions. I get some questions about copays in some of these virtual visits. Any thoughts about that?
Yeah, so copays were initially sort of suspended for virtual visits when they launched. And really, as of earlier this summer, almost all insurers that I'm aware of are now charging copays again for virtual visits. So copays and deductibles. So it's again, if the message is this is the same as an in-person visit, you're going to have a copay, you're going to have a deductible, you're going to get the same level of care. So yeah, those are back on the table, and we should be sort of warning patients that they may get they may get billed and they'll have a copay.
Excellent. Okay, seeing as there's no other questions, hang on a second. Dr. Boomer wants to know what are e-visits and what will they be reimbursed? Can you give a 2-second on that?
The 2-second is they're sort of text-based, sort of asynchronous, meaning you send a questionnaire, patient fills it out, sends it back to you, and you respond based on that questionnaire. Initially, they are not going to be reimbursed. MGB is looking at that. They are reimbursed at, like, the PHO will give you like $20 or $25 to do it, but we're not billing insurance for those, and that's another sort of hot topic right now, especially as we're going to have a much bigger launch in October.
Right. Some of our specialists who do e-consults now, it's kind of the same model. Instead of doctor to doctor, it's patient to doctor in that kind of way. Dr.
Thanks.
Kadar wants to know, how are you handling patients out of state at the time of the video visit?
Aran, you mean that you pop on and you find out that they're out of state?
Yeah, so it's come up a couple of times. At the end of the visit, they mention, "Oh, I happen to be in Florida or New Hampshire or wherever they might be."
It's a tricky one. It falls under the do what's best for the patient. So if you feel like you have to do that visit, do the visit, and you can. And I would just document in your note saying, I was unaware this patient was out of state until the end of the visit. For now, that's going to cover you. They always land on do what's best for the patient at the time.
Thanks.
Sure.
All right, well, next Thursday, we're going to be here, even though it is the Jewish holiday, Yom Kippur. I hope everyone who is celebrating has a safe and meaningful fast. Dr. Phillips will be in my place as guest host. Thanks, Jeff, in advance. And I will see you back in 2 Thursdays. And I hope everyone enjoys opening week this week for the NFL. And I'm really excited. Hopefully we can get a full season in again this year. So thanks again, everyone. Have a nice weekend. And thanks, Jeff. Great talk.
Thank you.